So we have a good mix of radiology and now kind of overpowers pulmonology. So I think 3:3, I'll join as a pulmonologist, Anshuman. Otherwise, it will be an unfair this thing. We will. This is obviously the thing. The title is Controversies to Consensus. So we will start with a controversy, and we'll take an opinion from the panelist first. Should we screen, and the chairpersons also, should we screen for lung cancer? Mike, please. And audience also. I think we can do that as make it a little bit interactive.
Hello.
Yeah. Just one yes or no. No dilly-dallying now.
Debatable.
Okay, debatable. All right.
I think we should screen, but screen smartly and not screen just more. Just
All right.
Smart screening.
Smart. Okay.
Debatable for our country.
Debatable for our country. All right. Audience, any opinion? Should you screen? How many wants to screen? 1, 2, 3, 4, 5, 6. How many don't want to screen? Is it automatic or? All right. Many people don't want to screen.
Not relevant in our country.
Not relevant in our country is a lot of field. So this is exactly the controversy. Obviously, screening means to find asymptomatic people, not people who are coughing and having breathlessness coming to my outpatient. So we're talking about asymptomatic people who are not experiencing symptoms. I'll start with the pulmonary colleagues. Actually, you want to take this question? Who do we screen? Or the question can be put as, what are the benefits of screening for lung cancer that you see? Whatever 5-6 points you think are.
So the benefits is the most of the patients that comes to us as a pulmonologist are at stage 3 or 4 disease for which the curative treatment can't be done. So if we target a specific high risk population, we can diagnose the disease in an early stage. So they can be curative treatment can be given, and there will be a mortality benefit, which has been shown in multiple trials that if we target a specific high risk population, the mortality benefit is there. And also the prevalence of the disease in the heavy smokers is considerable. Up to 2% the prevalence of the disease is there. And so if we choose the right population and do the right intervention, definitely it can be helpful.
Anshuman, I circled this high risk stuff. So who is high risk? So we say screen high risk patient. Am I high risk? Are you high risk? Obviously. Or is it only cigarettes, or what is high risk? Is a biomass exposure also high risk?
Exactly. So if we consider about the risk factors for this lung cancer, so, smoking is definitely comes in the first. But as you told that the BD smokers, the biomass fuel exposures, different hazardous occupational hazard, these also come as triggers or rather exposing factors for lung cancer. Now, if we consider male-female ratio, you can see this smoking in females automatically leads to malignancy in a very higher proportion compared to males. So if we consider the smoking female versus smoking males, obviously smoking females are more exposed to cancerous situation. So these are the things we should consider when we are thinking about the screening protocols or whom to screen. And I think these are the way forward.
Just a trivia. How many of you know in a pack of cigarettes, how many cigarettes are there? कितने लोगों ने सिगरेट खरीदा है अभी तक? पैकेट की औकात किसकी है? No, not many people can afford a packet. Especially as a student, you would have smoked, but you would never have afforded a packet. You would have got 1 cigarette, maximum 2 cigarettes when your father sends you money. So what does a standard packet mean?
10 cigarettes in a packet.
All right. The standard packet in the US is actually 20. So India is 10. ITC makes more money by that, I think 10. So 10 is there. How many in a standard BD packet?
25.
Very good. Somebody does smoke BD here. But it is not standardized. Many of our BD manufacturers do come to Apollo. It's a big industry in Bengal. So all the BD manufacturing, they come, they will put some are 15, some are 20, some are 25. So how to take pack?
Dr. Ramasubbam.
Yes.
So recently I met a patient. He has emphysema, obviously. And when I asked him, what do you smoke? So he said BD. I just generally told him that you have to quit it. So, sir, I cannot quit it. Why? So I am a BD tester. I just test the tobacco. Okay, that's a fair decision. Now, what he said is initially, so say 30 years before, they used to give 25 BD in a pack. Right now, they are giving 18 BD a pack.
Well-
Okay, that's
So this is the latest is 18 or 20 or sometimes even 15. So what is important is why this question comes is what is the number that people are where the cancer risk is high? Is it 20 pack years or 30 pack years? So that is one. And how is it calculated?
So the number of cigarettes the person smoked per day into the number of years that he has smoked, the number of packets, that is generally a pack year. So the trials which have been done, which has shown mortality benefits, two trials which have been done, an LST trial and a Nelson trial, both have taken around 30 pack years as the inclusion criteria. So
30 pack year is the golden number. One pack per day for how many years is what you have smoked? 30 is the consent. 25.
the trials.
Some people will even say 20, but what Akshit is saying is that in the two major trials, the Nelson trial and the NCLT trial, they use 30 as a cutoff. But yes, that is the controversy, whether you want to use 20 pack years or 25 or 30, and that is the controversy. One of the benefits of screening. Yes, we will come to that. Age of screening, is it 75 or 80? We will come to that controversy also a little later. One of the benefits of screening, which is sometimes not mentioned, is this one. That is, when you talk about screening, you also talk about smoking cessation. And one of the great side or corollary benefit or a side effect of CT screening is that maybe you are going to decrease the amount of smoking. Pitfalls of screening. We'll quickly, anyone wants to take that? Dr. Surabhi or Dr. What is the problem? If we screen with a CT scan?
I think the main one is basically over-diagnosing or diagnosing false positive cases that leading to over-treatment or unnecessary treatment.
Correct. So I think over-diagnosis and what we call as that the number of downstream procedures. That means if you find a nodule and you have sent for a bronchoscopy or a CT-guided biopsy or a PET CT, so those kind of downstreams procedure or harms of screening are also significant. Both the false positive rates are as high as 96%. So from a radiology perspective, Surabhi ma'am, what we would like to know is what can we do to decrease these kind of false positive? If you were to say, do a screening CT, you will find a lot of positive findings. So is there any way in which we can do this?
So the most important aspect of screening is that there has to be a standardized reporting format, which is available from the ACR, known as lung rads. I think Dr. Rashmi will detail us about it. But when we know that a particular case is undergoing lung CT for screening purpose, it would be a good idea to standardize the protocol, which leads to a more standard management protocol. So that would be my mainstay.
So Rashmi, I'll ask you, is there any way in which, what is this lung rads program? And just people working in different hospitals, is your radiology department reporting it this way?
So lung rats is basically used for LDCT, low dose CT. So as the name says, lung rats, it's lung imaging, reporting and data system. Here if you see a particular nodule, it is classified according to 4 categories. So it is 0, 1, 2, 3, 4, A, B and X. So what is it is that 0 is that the study is incomplete. 2 is that it is negative. So you've picked up a nodule which is negative. So the criteria which are used is the size criteria. And it also tells you that if you have picked up a nodule, when to call back again and when to do the screening again and how to manage it. So 1 to 2 is negative. 2 is benign, 3 is probably benign. So till 1, you are calling the patient back after 12 months. For probably benign, it is 6 months and the size criteria is 6 to 8. So the moment it becomes suspicious, so it again falls back into 4, A, B, X and S. So either you call back in 3 months or you do the guided FNAC or biopsy or a PET CT. So this is how you should do it.
So when you heard this term LDCT or low dose CT, what exactly does that mean?
So when you are doing a normal CT, the KV is 120, the MAS falls from 80 to 120. When you do a low dose CT, the MAS is reduced and it is 30 to 50 MAS. So when you're reducing the MAS, you're reducing the dose of the patient. That is important. And one more thing to remember is that the slice thickness is the same in a normal CT and LDCT. It varies from machine from 1 mm to 0.62 mm. So it's only the MAS which is changing.
So is it a contrast or a plain CT?
No, it's a plain
Plain
CT.
CT.
It's
Plain
just a
CT.
plain CT.
So you can't comment on the mediastinum, only on the lung parenchyma.
So basically on the mediastinum, if there are nodes, you will pick it up in a low dose CT only. The
Okay.
only thing contrast helps you is enhancement, non-enhancing or necrosis. But if given the opportunity, yes, the size criteria, you can pick it up even in a plain CT.
Okay.
So, Sudeshna, just we talked about this issue of in a nodule, benign versus malignant, ways to distinguish and say, if you look at these two and say which is benign, which is this thing, how do you radiologists go about it? How do you guys?
So that's one of the questions that we face very often when we are dealing with a solitary pulmonary nodule on a routine chest CT. So any nodule, we look at some characteristics which may help us reach a diagnosis of whether it is malignant or benign. So first of all is we look for any calcification. Calcification, some morphologies are suggestive of benignity of a lesion, like a central calcification, a lamellated calcification, a popcorn calcification, or a diffuse calcification. Whereas if the calcifications are punctate or small, the nodule becomes suspicious in morphology. Next is margins. As we all know, for all kinds of cancers everywhere, irregular, indistinct margins are associated with malignancy, whereas rounded margins, angulated margins are associated with a benign nodule. Shape again is important. So something which is spiculated is more suggestive of a malignant nodule. So this is a very good picture of a spiculated nodule. You can see those dendritic strands radiating from the nodule into the parenchyma, which are mostly suggestive of desmoplastic reaction around a malignant nodule. But if the lesion is round or angulated or flat, those are most likely due to benign nodules. Next is you need to look at how your nodule is in consistency. If it is a solid nodule, even though the popular belief is that solid is cancer and non-solid is not cancer, but in lung cancers, it has been seen that only 7% of the solid nodules are malignant, whereas ground glass density nodules or part solid nodules, that means the nodules which are center is ground glass, the periphery is solid, or vice versa. Those are very suspicious range and they are often cancer up to in 60 to 65% of cases. So solid does not always mean cancer.
I think this is probably the take-home message. I would
Yes.
say that
So,
from a radiology perspective.
The density of the nodule is very important. And in fact, the screening and the follow-up protocols for pulmonary nodule is dependent on the consistency of the nodule. A ground glass nodule or a part solid nodule is viewed with a much more suspicion. The patient is called back sooner for a scan, and they are often the ones which are more biopsied. And very important again is an interval growth. So again, no rocket science here. A thing which is growing faster is likely to be cancer. The doubling time for cancer nodules has been seen on an average of 240 days. On a regular routine screening, we say that if for 2 years a nodule is stable in size, we can dismiss that as a benign nodule. And anything which is growing faster in that period should be viewed with suspicion, followed up closely, or sent for PET or histopathology.
Perfect. I don't think anybody could have explained it better. Thank you
I'll
very
just
much.
add something because I see everybody's interpreting the images. So when a radiologist is interpreting the image, we have something known as MIP. So we always see the images in MIP. We see the images in axial, sagittal, and coronal. We measure the largest dimension in whichever scan it is the largest, and we give the mean diameter. So it's not the largest, it's the sum of the largest and the smallest divided by 2, and we give the mean. So this has to be kept in mind when measuring the nodule.
The controversy is nodules in the country with tuberculosis or histoplasmosis or fungal infection. Do we think, where do we go with this?
So I'm so glad, sir, that you raised this question. So when we were learning in our residency days about various imaging findings in a chest CT, we were told that tuberculosis can look like anything. And we are underprivileged in a sense. We live in a country which is endemic to tuberculosis. So often it is not very easy for us to differentiate. But again, the pointers that I marked out for a benign versus malignant nodule can be used. Also, cavitation is something that we see very often in a TB as well as in cancer. So the size criteria of a cavitatory nodule, which has a thick wall, the cutoff is 15 millimeters. So if the walls are thick, more than 15 millimeters, it is more likely to be cancer. If the cavitation is eccentric and not central, an eccentric cavitation is more suggestive of TB, of cancer, whereas a central cavitation is more suggestive of TB. Enhancement is plus minus. Cancers usually are more enhancing, but the slow growing cancers like bronchoalveolar carcinomas will not show the enhancement. Multiple nodules usually tend to be benign and can be of TB. And if you see your gones focus somewhere else in the epices, then you're likely to tilt towards tuberculosis. Lymph nodes will again not help you because necrotic lymph nodes can happen with TB as well as with cancer. So patient's history, demographics, whether it's a high-risk patient or not, and the imaging findings all together will help us reach, and when we apply the lung rats, that how malignant the nodule is to look at.
Quick question, Surbhi, is this is a standard question. You're going to expose myself to more cancer by doing this every year?
So, yeah, there is a definitive risk, but it's a very, very minor risk. If I had to give a context, then the amount of radiation for an annual screening program would be 1 millisieverts to 1.5 if you're adhering to the actual protocols which have been designed for lung screening, which compares to about 3 millisievert, which any average person would receive from the natural radiation sources in the environment. So if you compare, it's a very, very low amount of additional radiation that would be exposed to. And a general patient of lung cancer would have an estimated lung cancer risk of about 7 to 15%, which is way, way more than from a screening program like this.
So I think the message is not to be afraid of the radiation.
Yeah, less than 1%.
Despite this quick question. So how do we proceed? How do we actually screen in India, clinicians? Akshat, you want to take it?
So first we will need to define which population we need to screen. And the modality is, I think everyone knows low dose CT is the method.
So nowadays, I think low dose CT is the standard of
choice.
So there is no doubt the first two can be eliminated. So
yes.
Who to screen, when to screen, go ahead.
So the who to screen is the debatable question, because in India, the most of the smokers are BD smokers and it's not standardized. So it's very difficult to calculate the pack years from this BD, and one BD is not equivalent to one cigarette. So the ideal candidate is still debatable. And apart from that, other risk factors like biomass fuel exposure and air pollution, which is much more there in India as compared to the Western countries where all the studies have been done.
So let's go to when do we screen? Who do we? So that means what I'm asking is what age do we start screening? And as Dr. Arunava rightly said, till what age should we continue?
So according to the UPS STF criteria, it has to be started at 50 years and continued up to 80 years. So the first trial was started at 55 years, but the further studies have showed if we start a little earlier from 50 years, the mortality benefit is much more. So we have to start at 50 years, and it is advised to continue up to 80 years of age. An annual CT, low dose CT is advised, and but some studies have also tried the biannual approach. Instead of the annual approach, they have done the biannual approach, and they have seen that the mortality benefit is still there. So in future studies can further show whether a biannual CT, which will be much more cost effective, and probably the radiation exposure will be less also. And the thing is when not to screen. If the patient has a comorbid condition, which is significantly limiting his expectancy, life expectancy, then we should stop the screening of that patient.
So, Anjuman, we have these two major trials which have looked at Nelson trial and LDCT. Is there any data from India about low dose CT that we are aware of or anything?
I don't think so. We have.
It's still being formed. We don't have any established screening data.
So we right now do not have any standardized guidelines from us, but these guidelines are very clear that low dose.
There was one study which is unpublished from PGH Chandigarh. They have screened around 300 to 350 patients, and the malignancy rate was 1 to 2%, which is comparable to the NLST and the Nelson trials.
All right. So this is again to radiology. Yeah. So what do we do when you detect it?
So only thing I want to say is that if a screening program for a successful screening program to run, I feel that all patients who have been enrolled, they should be counseled that there is a chance you will undergo a biopsy which will turn out to be negative, and that they should be okay with it, especially in a country like India, where we have so many other endemic diseases which may mimic a cancerous nodule. So counseling the patient and be prepared for false negatives and false positives is what is the way to go.
So, Anshuman, so who will you suggest beyond the guidelines? Now, we discussed the guidelines. We know it's smokers. It's in India, it's difficult. So, who to screen? Which is a correct population you will screen and say, this is the gentleman that I would like to screen for. This is the lady whom I would like to screen for lung cancer.
So I think for that, the patient who has this lung cancer risk, we have discussed about that. I would definitely ask those patients who are smoker, who are more than 30 pack years of smoking. Those patients, I will definitely send for this lung cancer screening. And what she said about a proper counseling before the screening is very necessary. Otherwise, it might lead to unnecessary things, unnecessary medical problems. So I think these are the way, or these are the approaches we should follow.
So I think the thing is that it has to be an agreement, and you have to be in a multidisciplinary setup where if the patient needs a wax biopsy or needs a PET CT, all should be available in kind of a nearby area to do this, and everybody should be in the same loop rather than anything else. So last quick question, because we're running short of time, I'm going to just quickly say, so we realized that a 50 to 80-year-old smoker, even in India with tuberculosis, can undergo a low dose CT, and it's maybe beneficial. And if we are able to afford it, why not? So, but then question is, what are the challenges in one little word, and how can we overcome it? And what is the consensus of the panel? So everybody takes one thing. Is it doable? How should we do it? And quickly we will finish it off. And then any opinion from the audience?
I think with a country like India, the two major challenges would be, as already discussed. One is that it's a developing country still, and so we have a lot of infectious diseases which act as mimics to cancer. So to have a standardized protocol of reporting and to be able to do a good, thorough history and exam to identify patients who are at a risk of cancer and if the nodule concurs to one of the infectious pathologies rather than that, and obviously standardization of reporting for all of these.
I think standardized reporting is the number one thing that we need to get from. I think that's a message from all across. And the low dose CT actually should mean low dose CT rather than any CT and then not doing it. So I think that's the two message I would say from the radiology colleagues and from our practicing.
I think one thing we need to keep in mind that the patient who are getting exposed to radiation in the form of LDCT even, the counseling, what we are talking about every time, the counseling is very important. Other than what we saw in the first few slides, that over diagnosis or going to unnecessary interventions or investigation might lead to different problems. So I think this part is very necessary before we jump into the conclusion that we should go for a lung cancer screening in India. Because, another important thing is who will pay the price. Because we don't have a proper protocol, we don't have a government suggestion of what should we do, what not. So that is another issue we should raise, that who will pay the price. So if we overcome these burdens or these hindrances, I think this protocol can be run in India.
So this is the paper published in JAPI, which says that I don't think it is, this is from a consensus, expert consensus lung specialist in India. I personally do not feel that this is feasible, but I will leave it open to the floor and to the chairpersons to see where to end it. But I feel that personally, I think the first step for us is standardizing low dose CT and reporting by radiology, and then standardize multidisciplinary team approach for cancer screening, like we do in a preventive health checkup, not in our pulmonary OPD. That's my personal take on this, but open to the audience.
Suresh, one important controversy against this type of lung cancer screening, not only in lung, but this question has arisen in other disease sites like breast, that whether by screening we have been able to improve the overall survival, or it's a question of lead time bias, whether we are detecting just at the earliest phase of this natural history. And
In
If we
lung
could-
cancer, because the rate of metal is in your chances of detecting, because majority of the lung cancers detected are stage 4. So any detection in stage 1 or 2 will improve outcome. Is an automatic. It's a lead time bias is not. And the LDCT law and the lung cancer screening study published in NEJM in 2007 has said there is no bias. The biggest problem that they encountered in that study is over treatment, need for extra procedures and downstream procedures, and patients' mental makeup that will happen when you're worried that you have a cancer is what there. But definitely lead time bias in lung cancer is not there, because the detection by screening is in a very early stage and you prevent that. It's same as colon screening, as good as, like, because there is a standard evolution in colon cancer with from an adenoma to this thing. So I think the same principle, there's a lead time is pretty good in lung cancer. So it is applicable from that perspective, sir.
Just one point. Screening means something like a national program.
Yes.
What we do, it is called opportunistic screening. So-
I think the question is very good. What will you do if I come? Because most of us, people to us, come with some symptoms. Most of my smokers between the age of 50 to 80 would be coming for a chronic cough or a breathlessness on exertion. A smoker is not going to walk into a pulmonologist OPD saying, I want a checkup. That happens in the preventive and health checkup, where they get the corporate checkups done,
General
where you
practice
have a
process.
history taken that they have a smoker. And then what is the primary health, healthcare provider and that doctor, what he does is what this is meant for. As a pulmonologist, me and Anshuman and Ankit, we are going to see patients who are symptomatic.
We think we are exceeding
Yes.
time. We should conclude.
No, no,
here.
no.
I think we
Just
Suresh,
one question.
what I mean to say.
Correct. That is so. The primary
that
health
is-
center is when people are going for a checkup for their well-being.
Yes, for opportunistic screening, we should encourage people to go for low-dose CT scan
Correct.
because that reduces mortality by 20%.
Thank
So
you, sir.
that is
Sorry, ma'am,
important.
for
Sir,
taking.
one question, because prevalence rate of tuberculosis is very high in our country. So many times we see that tuberculosis and malignancy are coexistent in the same patient. Because PET CT is false positive for this tuberculosis. So how will you diagnose it by other imaging modality?
So a PET CT again has a controversial role because an inflammatory process and some cancers which are less aggressive will have similar SUVs on PET. So those are the patients which you biopsy. So you will see in a patient the
And
most
radiologically,
suspicious.
how can we diagnose? Biopsy is okay. Radiologically, is there any?
So obviously, ma'am, any one particular focus which has all the malignant features that I discussed, if it is larger in size with spiculated margins, with an eccentric cavitation, irregular walls, that is the one I would think of as a cancer. And if it is separate from the rest of the focus, like if it's a upper lobe TB and I have a separate nodule in a left lung lower lobe, which is looking suspicious. So that is what I would like to go for further imaging and
Our
diagnosis.
problem is contouring, what should we contour? That's why I asked. Anyway, excellent discussion. It's an excellent discussion on preventive oncology. Okay, so we can conclude this session now. Okay, thank you.
Thank you, Suresh sir, and all the panelists for an excellent discussion. Let's have a photograph.